Hi, my name is Troy McGrew, and I'm an endodontist in practice in Charleston, South Carolina. I've been practicing endodontics over the last 15 years. And what I hope to discuss with you today is the process of posterior endodontic access. In this concept, as all concepts of the endodontic process, we've learned that learning is ongoing. In 1997, I became board certified with the American Association of Endodontics. It was at that time my practice changed. I learned that the educational process is evidence-based, and it's one that we must strive daily to improve upon in all that we do in this endodontic process. In my own educational experiences, I have learned that every day the concepts of all endodontic principles need to be evaluated and that we can continue to improve our own personal skills. Posterior endodontic access for me is something that I continue to improve and that I continue to enhance daily through the treatment of my patients throughout my practice. And what I hope today to do is to share with you a few concepts of endodontic access that will help you gain confidence in the way you treat your patients and to improve upon the endodontic outcomes that you can provide. Now let's get started. We first must understand the canal morphology and the complex systems that we'll be treating. The astute clinician must understand that the canal morphology will have a direct influence on the outcome of the case that they're treating. If we act as if the canal morphology is unimportant, we will underestimate our ability to address all of these issues in the instrumentation process, which follows the actual access preparation. It's a complete understanding of the complex canal morphology that will lead us to the successful treatment in our patients and the successful outcomes that we all desire. Fundamentals of access preparations. First, they must permit the removal of the entire chamber contents. When you look at the picture presented of the posterior access preparation, at first glance you may feel that that's an adequate preparation that allows adequate access into the canal system. Upon further investigation, we realize from a lateral view and with the help of an explorer that portions of the roof have yet been uncovered. And in this process of uncovering the roof, we also remove the remaining organic and inorganic debris within the canal system. Failure to do that will leave contamination inside of the root canal system that can lead ultimately to failure of the entire case. So astute attention to detail must be used when determining adequate size and adequate removal of the chamber contents. On second glance, after refinement of the access cavity, we notice that now we have adequate vision and that we can be assured that all the contents of the chamber have been removed. Secondly, our access preparations must enable complete direct vision of the pulp chamber floor and the orifices. It's clear that after refinement, we can see easily all of the main orifices of the canal system. They're easily identifiable, and we can follow the natural dentinal map that occurs in posterior teeth. Following this map and following and locating these canal orifices allows us to adequately treat and disinfect the canal system. Thirdly, we want to facilitate the introduction of endodontic instruments into the radicular pulp. The radiograph demonstrates in the distal canal you can clearly see easy entry of the file into the not only coronal aspect of the pulp, but free access into the apical portion of the distal canal. Notice the dotted line to the left that encompasses or that includes the mesial canal preparation. The interferences at the coronal aspect of that will not allow efficient entry of the canal, of the instrument into the canal space, limiting the efficiency and the outcome of the success of the instrumentation process. What we desire to do is to establish a straight line access that enables easy entry and instrumentation of the canal system from the coronal aspect all the way to the apical aspect of the canal. You can see with slight modification of the coronal aspect of this cavity preparation that we now have direct line access and straight line access into the mesial canal system as well. The fourth fundamental describes straight line access. Notice the radiograph to the left. There's a distinct wedge of dentinal debris, of dentinal anatomical consideration at the entry of both the orifice of the mesial and distal canal. This sharp curvature does not allow straight line access or easy entry into the canal space apically. If we blow this radiograph up and take a look at a larger size, and even change the animation to that, providing you with a collared seal of the actual dentinal wedge of tissue that remains, the hard tissue that remains, at the coronal aspect of the chamber and the coronal aspect of the actual canal space. Removal of this dentinal wedge of dentin debris will allow us straight line access into the canal space so that the file can instrument the entire length of the canal system from the coronal aspect to the apical aspect with straight line access in the most efficient manner. The fifth fundamental, we must provide a positive support for temporization of the case after the process has been completed. Lack of this support will provide an opportunity for the interim restoration in the temporary material to actually collapse into the tooth. These implications can include anything from complete failure of the case, but to complete recontamination of the actual process that you spent so much time disinfecting, cleaning, and sealing that is all to be lost through an inadequate support for temporization of your case. An adequate preparation should support the temporary material by the walls that diverge as they move coronally. Without this support, again, the temporary material or even the permanent restorative material will collapse into the canal space or into the chamber space, recontaminating the system completely. When you notice, the proper access shape should, again, it should diverge as you move coronally and converge as you move pulpally toward the pulpal floor. It is this flare and this divergent that provides the actual support for the temporary material inter-appointment-wise. And lastly, point number 6, always have 4 walls. When treating endodontic cases, especially in the posterior, that have a large expanse of carious activity or loss of complete tooth structure of any sort, this needs to be rebuilt and restored before the process can continue. This process of restoring the tooth allows you to adequately create a space so that you can not only seal the tooth with the rubber dam, that you can maintain asepsis, but you can also provide a reservoir for the chemicals used in disinfection of the canal process, of the canal system throughout the endodontic process. Without proper isolation and without proper restoration of the tooth preoperatively, we always run the risk of contamination and less than perfect asepsis during the procedure. So take the time to restore the tooth, to rebuild the lost walls due to caries or even traumatic events so that we can adequately disinfect and seal the tooth. Next, let's talk about access cavity outline forms. When we consider where the actual orifice is in relation to the coronal tissue in the tooth, we see that there is a lot of variation between the anatomical reality and the actuality of the canal system. Notice the purple dots on the dentiform, on the picture of the dentiform that is before you. The purple dots represent where the actual canal orifices are the majority of the time. Although this is not set in stone, it is a good idea, and again, understanding the canal morphologies, but also understanding where these canal orifices may be located before we actually access the tooth and penetrate into the canal system. On the mandibular arch, we notice that although there is some similarity between the maxillary arch, there are some anatomical differences that we should consider. In noticing, too, that most of the canal orifices are favoring toward the mesial of the tooth, therefore, we shouldn't start our preparations to the distal of the tooth, violating the structural integrity of the tooth. Understanding where these orifices lie beneath the hard structure of the enamel, the occlusal, and lingual surfaces of the teeth will allow us to conserve tooth structure while adequately preparing our posterior access for root canal therapy. Notice again, in premolars, the shape is important so that we can address all of the areas or all of the anatomical realities of the particular tooth we may be treating. In the case of premolars, we understand that we have a ovoid preparation buccolingually. That's necessary to treat the broad nature of the canal space that lies within the coronal chamber of most premolar teeth. Notice again, from the mesial aspect, The access needs to be ovoid and broader from a buccal to a lingual access so that we gain the straight line access and so that we have complete visualization for treatment of the space and treatment of the tissue within the canal system. Again, premolars as well can have complicated anatomy. If our access is inadequate or underdone, we run the risk of leaving canals untreated, leaving behind not only organic but inorganic tissue as well that could compromise the endodontic result long term. In premolars, 93.3% have 2 canals. This is the most common case that we see in the premolars, but notice too that 6% can have 3 canals. Understanding that the multiple canals and anatomical abnormalities can occur, we must enter all teeth that we treat endodontically expecting to find the unexpected. I tell my patients, I tell my students as well, always expect the unexpected until it's ruled out. So knowing the anatomical realities in some cases can be very important in the shape and design of your posterior endodontic access. Also, before you enter or penetrate or even place a burr in the area of a posterior tooth, always in your mind visualize where the pulpal floor and the dentinal map may be within that canal system. It's a good idea in knowing the anatomical realities before we start that can limit the unnecessary removal of tooth structure, that can limit the unnecessary weakening of a tooth, making it susceptible to fracture and breaking down the road, thus limiting the success of long-term endodontic outcomes. As you can see with the radiograph or the picture in front of you, that the anatomical reality is completely encompassed within the outline of the eventual canal preparation. And this can also help us avoid many problems when we're looking to stay away from the things that may limit our success, and those could be avoiding perforations. When we look at this information and we look at the reality that perforations in teeth can be a leading factor of the loss of teeth, understanding the landmarks that are common from person to person, from tooth to tooth, in human maxillary and mandibular teeth can help us as we look into our preparations and we begin to prepare to access these teeth for endodontic therapy. In reality, many of the cases are so similar, many of the teeth are similar person to person, we can bank on the fact that we have these similarities and these consistencies to limit the problems that may present themselves during the posterior access preparation. In this study, actually 200 teeth, 100 maxillary and 100 mandibular teeth were analyzed. The authors looked at the probability that within these teeth there was consistency between certain measurements that influenced the outcome of successful endodontic cases and in providing successful posterior endodontic access. And what they found by a representation by the letter A, you'll notice that in mandibular and maxillary teeth, the average distance from the pulpal floor to the furcation, the area most vulnerable to endodontic perforation during access, was approximately 3 millimeters. This is valuable information to understand that the structural integrity of this tooth is maintained primarily by this portion and should not be violated during endodontic access. Secondly, the pulp chamber height is represented by the letter F on the diagram to the left. In mandibular molars, the value of the actual height from the pulpal floor to the roof of the chamber was found to be on average 1.5 millimeters. And in maxillary molars, that distance was found to be closer to 2 millimeters. Although there is some variation, it gives us a good idea as the amount of space that we have before we will violate into the A value or the value of the furcation thickness. And we look at another aspect from the buccal cusp to the pulp chamber roof in mandibular and maxillary molars, and this diagram is represented by the letter E. We find that it's consistent between maxillary and mandibular molars to the tune of about 6 millimeters. With this information, knowing that each case we begin our access, each case we begin to treat endodontically, we know that we can confidently remove this tooth structure without the probability of damaging the tooth or ultimately creating a failure because of an iatrogenic perforation or indiscriminate removal of tooth structure. So understanding these concepts is crucial into our understanding of proper endodontic access preparation in the posterior. Again, if we look at other important information that can help us limit and that can help us design our posterior endodontic access, we also understand that in most cases, it is consistent that the CEJ and the actual roof of the chamber coincide in over 98% of all mandibular molar teeth, as well as 97% of the time in all maxillary molar teeth. Now, what this means is the following. If we visually inspect the tooth before we gain access, before we even penetrate the actual occlusal surface for access, we know that if we can locate the CEJ, that we can arbitrarily determine where the roof of the chamber, our ultimate goal for the initial penetration access, will be without overdoing or stepping into the more vulnerable furcation areas. This is consistent through all human teeth, maxillary and mandibular, and is something that can be taken into account to prevent and to try to avoid access errors. When we are using and doing a pre-operative exam of our teeth, use of a periapical radiograph is not the best thing to use for measurements and for giving us an idea of the depth and penetration of the actual or the impending posterior access. The reason being is most periapical radiographs, even when taken with the best efforts to maintain a parallel outcome, even with paralleling instruments, there will still have a suitable vertical angulation that will alter the ultimate values for the depth and the length of tissue, hard tissue that is above and below the chamber in terms of the furcation and also the roof of the chamber. So periapical radiographs are ultimately inaccurate in the sense of not good tools to determine what aspects we want and where we need to set our stops into creating posterior access. Instead, we should consider bitewing radiographs. Bitewing radiographs by nature are taken at a more direct, at a more parallel aspect so that measurements can be more accurate and more determinate of the actual outcomes or the anatomical realities within the tooth. If we look at two methods of preparation or pre-preparation techniques in determining the depth and determining the aspects of posterior canal preparation, it will help you lead to more successful, less invasive, and as well as adequate preparations in your posterior access for endodontic therapy. First, we want to take the measurement from the access of the pulp chamber to the maximum height of the tooth, which is represented by the yellow line on the radiograph to the right. This actual distance is from the highest anatomical point on the bitewing radiograph and down to the roof of the chamber of the tooth. Next, we choose the highest point of the roof of the chamber, and we identify this point mentally from the use that is the point that we will first gain access to upon penetration phase of the actual posterior access. By knowing this point, again, we avoid penetration and violation of the furcation tooth structure that will greatly weaken the tooth and also make the tooth more prone to fracture, eventually failure possibility if that is violated. So by identification of the highest point of the pulpal chamber roof, it gives us an important aspect so that we know where we are first to encounter the actual contents of the pulp chamber. Then we want to identify the highest reference point on the tooth through the radiographic exam or through examination of the bitewing radiograph. This allows us to, again, measure from that point down to the actual roof or the highest point that's already been identified on the radiograph. It's this point where we can expect penetration into the canal space. That penetration that's felt as a drop into the canal space is a familiar feeling that we all have and desire once we reach a certain distance where we may be becoming a little nervous from a standpoint of possible penetration or too excessive of a penetration into the canal space. By identifying these two positions, the highest reference point on the tooth and the highest point of the actual roof of the chamber, it gives us the safety in knowing of where we are at all times within the canal space. Notice the use of a burr in the radiograph. What that burr will represent is the depth of penetration along the shank of the burr toward the pulpal contents or the pulp chamber of the actual posterior tooth. And what we want to do is mark the area of the file so that once that depth is reached in conjunction with the highest point on the tooth that's been identified, we know that we are somewhere in the proximity of the roof of the chamber of the tooth. Therefore, building in an added degree of safety and an added degree of success for long-term down the road in creating our adequate posterior access. And lastly, once we penetrate to that depth, we want to stop with apical progression of our preparation process. Violation of this needs to be considered an error in violation of the pulpal floor, contamination or actual destruction of the pulpal floor, and the furcation area of the pulp chamber needs to be considered something that we want to stay away from, and we must always strive to maintain the natural anatomy of the pulpal floor, not to violate the furcal area. So once this is reached, once this length is reached, we want to stop the process of penetration. We want to adequately examine and see with an explorer, with another instrument of exploration, where we are. Are we in the chamber or are we not? Any further removal of dentinal material needs to be done judiciously, cautiously, without large expansion or without large movement into the furcal area of the preparation. In our second method, we utilize many of the same principles, but understanding that instead of using a file, we can also use different instruments. Anytime we can magnify a radiograph, anytime we can magnify, give a brighter, a larger example of the subject at hand, it's going to enhance what we do, not only in measurement, but also in identifying anatomical realities and anatomical changes that may be pertinent to the tooth we're trying to treat. So I highly encourage that you magnify any image that we see in making measurements that will ultimately affect the depth, the penetration, and ultimate success of your posterior access cavity. After we do this, what we want to do is identify the actual depth from the floor of the chamber to the actual highest point on the tooth. In this particular tooth we're looking at, being tooth number 3 in the maxillary arch, we notice that the depth of the actual penetration down to the depth of the actual floor of the chamber up to the highest point on the tooth anatomically, again, coincides, if you notice the line to the left extending out to the CEJ, thus confirming the 98 and 97% respectively that we spoke of earlier. Knowing that this area being the roof of the chamber and gaining this measurement can help us in preventing iatrogenic errors through perforation or excessive removal of tooth structure. Also, let me say it's very important to know your limitations. It's very important to know that when we feel uncomfortable with providing treatment for our patients, that it is our responsibility to refer. It's our responsibility to refer the patient to an endodontist that may be able to offer not only an advanced system for preparing these teeth, but also in completion of the entire endodontic case through illumination, magnification with the use of the microscope, as well as experience in treating these complicated cases, more posterior, more calcified, more curved, more constricted cases. So know when to refer, know your limitations, and don't place your patient at risk by altering what you do based upon your desire to learn or to do things that you feel uncomfortable with. Our examination of method 2 will continue with looking at number 30 on the mandibular arch. And utilizing this method again, we notice that magnification will allow us the opportunity to better see not only the anatomical variations, but the anatomical realities within the tooth. Notice here that we can clearly see through magnification the pulp horns both on the mesial and distal of tooth number 30, which will be an important reference point for us in determining the penetration depth of our posterior access for this case. That's represented by the actual yellow line from a distance to a point at the highest anatomical point visible on the radiograph. Again, the highest anatomical reference point occlusally down to the roof of the actual chamber is recorded in this case as 7 millimeters. We used a periodontal probe to determine this length. We gain that information, we record that so that upon initial penetration, we're not in danger of violating the furcation, weakening the tooth, making it more susceptible to failure in the long term. And again, to reiterate, preoperative restoration of the tooth is crucial, not only for maintenance of our chemicals of disinfection, but also in providing a seal that will provide us with the ability to aseptically provide a restoration that will not allow recontamination of the case that we work so hard to prepare and to decontaminate. The radiograph on the left demonstrates the mesial carious lesion of number 30. If you notice preoperatively on the radiograph on the right, you notice a preoperative restoration of the tooth before instrumentation and completion of the endodontic procedure has been accomplished. Taking the time to provide 4 walls, to provide the isolation through preoperative restoration is never underestimated and cannot be considered something unimportant. We have to discipline ourselves to provide us with 4 solid axial walls for the retention of chemicals and for disinfection of the canal space. Access cavity preparation can be divided into 3 different sequences. The first of those is the penetration phase. The second is actual enlargement of the access cavity, and the third is refinement of that cavity. They each have individual nuances that we will take some time here to identify and to expand upon on each individual point. Upon the initial access of the tooth, we enter the penetration phase. The armamentarium for the penetration phase, for the actual enlargement phase, and for the enhancement phase are somewhat different, but should be considered as the armamentarium for the access cavity preparation. Notice that on the upper left-hand side for chamber access, we have an example of a number 4 round burr and most commonly used in posterior access preparation. This is your preference completely. You could choose to use a straight access burr, you could choose to use an 1158 rounded tip Fisher burr. It's really whatever you're comfortable with, but it should be in cutting and something that is small enough to not remove excessive tooth structure as to further weaken or indiscriminately remove tooth structure. As we move to the refinement or to the scouting phase, you notice you have a G16 Endodontic Explorer to the right of that. This instrument is intended to find the large orifices, to identify to you the location of the actual entry into the canal space. Upon location of the main orifices of the tooth, we can then refine the outline of the chamber. The most common method, and one I would recommend to you, would be through the use of the access burr. The access burr is one that provides us with the flare we discussed earlier in maintenance of the support of the actual temporary at the conclusion of your treatment. It provides us with an inlay preparation, if you will, in the shape that we need to gain direct vision, to gain direct access into the canal space, as well as support of the temporary. This particular instrument provides us with several safety features. One, it's a broad fluted instrument, and it's not going to aggressively remove tooth structure, but instead it will do so in a more refined nature once the chamber has been identified. Considered, if you will, as the finishing touches in providing that last visualization you need to complete the further aspects of the endodontic therapy: instrumentation, irrigation, obturation. Also of importance would be the non-cutting tip that is on the actual access burr. You cannot violate that sacred furcal area that we talked about once this burr is introduced into the tooth. It will not penetrate the tooth apically. Instead, it will laterally prepare the canal space in a way that will provide us with direct visualization and direct line access. Lastly, in the lower right-hand side, you will notice refinement burrs for radicular access. These burrs are intended to, these drills, these files, however you wish to refer to them, they're basically orifice shapers and access refinement instruments. What their intention is to do is not for main or middle to coronal 1/3, middle to apical 1/3 instrumentation. Instead, these instruments are designed to refine and to delicately change the arrangement of the radicular portion or the coronal aspect of the actual orifice. We want to remove things such as interferences, calcifications, as well as that dentinal wedge of tissue that we discussed in providing straight line access. We do that with introduction of the radicular access instruments and through lateral flaring toward the safety areas away from the furcation aspects in the tooth and of the chamber that we have created. In review, we have penetration burrs, we have exploration instruments, and we have refinement instruments as well as radicular access instruments. They can all be found in an Endodontic Access Kit. There are a number of these kits available on the market. The Endodontic Access Kit is a way that we can collect the necessary instruments to provide us with adequate posterior access. When you notice, all of the instrumentations we spoke of are available within the Endodontic Kit and the Endodontic Access Kit for quick reference and for quick utilization. The Endodontic Access Kit provides us with penetration burrs as far as a round diamond number 2, round diamond number 4. Also, in cases of teeth that are prepared or that have already been restored with a crown that has a metal substructure, it may be necessary to have a transmetal burr or a round carbide number 2 or number 4. Again, the Pulp shaper burr is adequate for fine refinements of the actual axial wall. Limited two-structure removal as compared to penetration, we want to basically outline and refine the axial wall so that we gain the straight line access, so that we gain adequate visualization of the anatomy of the posterior access and the posterior canal system. I want to pay some particular attention to the X-gates that's available. And what the X-gates is, it actually provides us one instrument, which is a radial landed instrument for safety, that will take the place of the gates drill number 1, 2, and 3. So in one instrument, we can accomplish through judicious removal of that dentinal triangle, we can provide straight line access for further eventual efficient use of the instrumentation system you choose to implement. So again, through the use of an armamentarium kit, it's important that we have all of this to our access for quick utilization in preparing our posterior endodontic access. Let's discuss the penetration phase. The penetration phase can be defined as that phase where we initially penetrate the enamel of the tooth into the dentin toward the actual chamber of the tooth. Remember, our goal is to approach and to reach that point of the highest, most prominent portion of the roof of the canal space. Any further apical progression of the penetration phase will only weaken the tooth or create a higher incidence of furcal perforation, which again can ultimately decrease the chances of a successful outcome of our endodontic case. So, we advance the number 4 round burr toward the highest, most prominent place on the chamber ceiling so that we can feel that characteristic drop into the chamber. Remember, upon realizing that characteristic drop into the chamber, any apical movement at this point is halted. We then transfer into the actual location of the orifices. We want to get an idea through the use of the DG16 Explorer. Where are the general locations of the large orifices and the canal spaces within the penetration that we have created? Once we have identified the location of the orifices, eventually which will become the orifices that lead into the cleaned, disinfected canals, we want to smooth and flare the walls. We utilize the access burr that we spoke of, which is a non-end cutting tip with a large flare, providing us with that support of the axial wall without excessive removement of the axial wall, which will again further weaken the tooth. But by use of this refinement burr, we will actually provide direct visualization of the case, of the canals, so that our instruments that we will be employing into the instrumentation process will be efficient and can be done confidently without the introduction of forces that may inadvertently lead to fracture or other difficulties with the instrumentation process. So by by access refinement, we're providing ourselves with that direct line access to the orifice, direct visualization of these orifices, thus limiting the potential of iatrogenic errors or errors during the instrumentation phase. Again, you can see that knowing tooth morphology, knowing what is normal and what is abnormal, is crucial into providing successful access and eventual successful endodontic therapy. Let's take a look at some of these normalities and some of these abnormalities. Maxillary first molars, in considering the average length of the maxillary first molar in the human dentition is 22 millimeters. The crown of that tooth is actually 8 millimeters on average. The root of the tooth, the mesiobuccal root, 12.9 millimeters. The distobuccal root, 12.7 millimeters. The palatal root at 14 millimeters. Root length is defined not from the highest point on the tooth, but actually from the coronal aspect or the orifice of the canal on the floor of the chamber to the apical extent of each root. Notice too that the shape of the mesiobuccal root is more buccal palatally wide, broad, ribbon shaped. This is important because once we have identified the mesiobuccal and the mesiobuccal 2 canal, we understand that special attention has to be given to this tooth in the instrumentation and disinfection of this canal system. Notice that the palatal root and the distal roots are mostly round in nature, exhibiting less of that large buccopalatal ribbon shape of the mesiobuccal root. Also, to further take this in more detail, notice that the mesiobuccal root, 90% of the time, in my experience, it's probably more than that clinically. You have an incident of actual 2 canals within the mesiobuccal root. There's a second orifice located normally 1.82 millimeters palatal to the main mesiobuccal canal. And in knowing this, we must understand that 29% of the time, it's a type 1 configuration, meaning that there's only one canal. 39% of the time, the second canal may have 2 canals that will basically join and have one common terminus of the mesiobuccal root. So for instance, we may find 2 separate canal orifices on the mesiobuccal root, and upon instrumentation notice that they both exit from a common exit apically. And 31% of the time, we can have one orifice on the mesiobuccal that will actually turn into 2 separate canals, but then recombine for one canal apically. And this is a type 3 configuration. Again, the distobuccal root as well as the palatal root predominantly are one canal systems. But also a point must be made that 85% of the time in the palatal root, there's a curvature greater than 10%. This curvature actually occurs more apically, therefore creating stress on the eventual instrumentation process, which could lead to instrumentation errors. So understanding these nuances of anatomical variations, of anatomical differences is important not only upon the instrumentation phase, but our initial access into the canal space. For instance, if we don't give adequate preparation time to the incidence of a mandibular or mesiobuccal 2 canal orifice, we are grossly under-treating these systems. 90% of the time, likely higher, we will find some sort of an anatomical variation leading us to 2 canals or at least 2 canal systems that need to be addressed in the mesiobuccal root of maxillary first molars. In these pictures of the facial view of maxillary first molar, notice that the anatomical complexities can sometimes be masked, and notice that it looks fairly innocuous. When we look at the canal shapes, we look at the actual shapes of the roots of the tooth. On the picture all the way to the left, it fits more of a common thought that we have for the shapes of these roots. Notice, however, the complexities on the middle picture of the 3-dimensional images here, that the anatomical complexities within the root canal systems are great and are varied from even canal to canal. And then on the far right side, we see a radiographic examination in 3 dimensions of the actual internal anatomy of the maxillary first molar. And then we look at a proximal view. Notice at this point, the complexities change because we now give appreciation to the fact that in most maxillary molars, we notice a broad buccal palatal formation of the actual root or orientation of the root. The broadness dictates that we look for the anatomical variations that we know are present from either an extra root that's in the tooth in the form of a mesiobuccal canal, or at least tissue in that broad ribbon shape of the canal that requires brush filing and enhanced irrigation techniques. Notice in the middle picture as well, it gives us a good visualization not only of the broad mesiobuccal root, but notice the apical curvature of the palatal root that we discussed. That's there 85% of the time apically in the palatal root canal systems. And again, this is confirmed radiographically in 3 dimensions, all that we discussed, the complexities of anatomy, the presence of an extra canal, the mesiobuccal root, and the apical curvature in the palatal root. In the lingual view, we notice the same complexities and some irregularities anatomically that we've noticed in the other views. From the lingual aspect, notice that the thickness of the roots and the anatomical internal variations are present as well. And again, in the radiographic examination of the 3-dimensional view, we again can appreciate the anatomical variations and the considerations that we must take into account before we begin our posterior endodontic access. When we look at cross-sectional pictures for the maxillary first molars, I want you to appreciate the variations from the coronal to mid-root to the apical thirds of this particular tooth. Notice in the coronal cross-section how we see a wide variation in not only shape, but the number of treatable orifices that are present. And when we move to the mid-root, although we get less of a variation, we still see a very prominent variation from the actual roundness of the canal from, say, the mesiobuccal or the distobuccal and palatal canals. It's this broadness, this anatomical variation, that proper access will allow us to treat endodontically for better, enhanced, successful outcomes. And apically as well, we can appreciate throughout the entire root canal system, from the coronal aspect to the apical aspect, the anatomical variations that are present within this tooth. It's always an interesting way to break down a tooth in cross-section to see exactly what we're trying to achieve in endodontic therapy. And again, this video is to demonstrate the penetration phase of the actual endodontic access preparation. With the round burr, you notice a penetration phase to the highest point of the actual roof of the chamber. Notice the drop through, the sensation of dropping through, and then with a brush technique toward the coronal, we enter into the enlargement phase, ridding of any overhang of the pulpal chamber ceiling so that all debris, organically and inorganically, can be removed. Now we're refining the actual shape of the canal access, and then we see we're providing that direct line access into the actual coronal aspect of the canal system while providing support for temporization. And finally, with the picture, you notice the actual access preparation in proper shape and form. Now let's look at the mandibular first molar. On average, the length is 22.5 millimeters. The crown of the mandibular first molar is 8.1 millimeters on average. The mesial root is 14.4 millimeters. The distal root is 13.5 millimeters. Again, there's a broad mesial root in the terms of a buccolingual type of a projection that has to be addressed from a standpoint of instrumentation and at the stage of posterior access. It's in the shape of a kidney bean or an hourglass design. Many times there can be confluence between both canals, say the mesiobuccal and mesiolingual. In some cases, it's actually one separate canal. In some cases, it's actually one large canal with one common terminus. The actual distal root in the mandibular first molar is actually more of a rounder, broad buccal lingual direction in shape. We also have some variations that we need to consider when we talk about the mandibular first molar. In the mesial root of the mandibular first molar, 12% of the time there's only one canal, and we consider that a type 1 canal configuration. 22% of the time you'll notice that there will be one canal that will branch into two canals and actually form one canal for a common terminus from the canal system. And this is known as a type 3 configuration. And 43% of the time, or the majority of the time, we have two separate canals in a type 4 orientation. In considering the distal root, notice that 70% of the time, or the majority of time, we have one canal with one common exit. This is known as a type 1 canal configuration. And 15% of the time, there may be two canal initial orifices that will join to form one common exit, known as a type 2 configuration. 8% of the time, we have one canal that may split apically into two separate exits of the canal system, known as a type 5 configuration. Having an initial understanding of these anatomical variances is crucial to proper endodontic access in the posterior as well as instrumentation of these canal systems. And when we look at a three-dimensional view of the mandibular first molar, notice the complexities of the actual root diameters and the actual arrangements of the roots appear to be ominous again. When we look at the middle picture, we notice that the representation of the actual pulpal spaces are somewhat complex as well as tortuous and not what it appears to be to the picture on the right. And as we notice radiographically, the three-dimensional view of the mandibular first molar, the anatomical considerations of thickness and where these actual canal spaces lie in connection to the actual furcal areas and the actual thin places in the interior or the furcation areas of the tooth are somewhat ominous and can need to be considered from a standpoint of too much enlargement, possibly strip perforating a tooth and leading to problems for success down the road. Now let's look at the lingual view of the mandibular first molar. Notice the narrowness of the roots and also the anatomical complexities that present within the root canal system. These anatomical complexities have to be appreciated and have to be realized at the point of access preparation so that these problems don't present themselves in the instrumentation process and can be overcome adequately in the treatment of this root canal therapy. We must pay special attention in the initial aspect of access preparation so that these don't present as larger errors in terms of perforations, transportation of the actual canal spaces, and other iatrogenic errors that may limit our success to cleanse and seal the root canal system. Paying astute attention to detail can allow you to confidently treat and prepare these teeth in such a way that the desired outcome can be met consistently and efficiently. Again, when we look in cross-section, the mandibular first molar presents its own complexities and its own irregularities. Notice that in the coronal aspect, we see separate orifices in all of the canal spaces, being the mesiobuccal, mesiolingual, and the distal canal. As we move into mid-root, these further separate into a more ovoid shape, and they also present themselves as two separate canals with a connecting isthmus or connecting bridge of tissue that has to be addressed through our instrumentation, which can only be effectively done through proper canal access preparation. And notice the broadness mid-root of the distal canal. And apically, we notice that there is loss of that broadness coming more to the centralization of one terminus, but we cannot neglect the presence in the mid-root and the coronal 1/3 as far as the anatomical irregularities for the mandibular first molars. They must be appreciated for proper cleansing and sealing of the endodontic case. To take it a step further, a key point in learning and a key point for us to avoid problems is understanding the furcation danger zone. The redness that you see represents the actual location of the internal canal anatomy, the presence of the canal anatomy in connection to the anatomical realities of the external tooth structure. Notice the depression of the lingual root. If the canal space is over-prepared internally, we will see the possibility of a strip perforation, which can lead to failure of the case long term. Notice that in most cases, 0.75 millimeters or less than a millimeter is the distance that represents the actual axial wall of the canal preparation in about the area from the coronal to the mid 1/3 of the tooth is only 0.75 millimeters or 7/10 roughly of a millimeter in thickness. Over preparation in this area can lead to strip perforations. This needs to be considered at the time of access so that we can remove interferences which may introduce problems in this area. Believe it or not, the crucial aspect for overcoming these problems occurs during the access preparation through direct line access and removal of coronal interferences through the use of radicular refinement and also access refinement burrs. This is an example of the initial penetration phase for a mandibular molar access. Notice through the penetration phase, we're going for the highest point of the actual ceiling of the canal of the chamber. Once that's reached, you see that characteristic drop into the chamber, which then we want to basically, we're trying to locate the location of the main orifices and the main entry into the canal spaces. From that stage, we want to enlarge with brushstrokes coronally, getting rid of any overhanging dentinal chamber ceiling so that all organic and inorganic debris can be removed. And then we want to basically move into the refinement stage so that we can create the access that we will want to support our eventual temporization of the tooth and allow us direct line access for efficient instrumentation and disinfection of this entire canal system, resulting in a nice cavity preparation. In detail, the mandibular molar, the pulp chamber many times is mesially placed. The shape of the outline of the actual posterior access is trapezoidal in shape. One distal canal in most cases provides us that we can have a more of a broad triangular shape as compared to the trapezoidal shape. That will take place upon initial penetration, outlining of the canal space, and refinement of the canal space. In cases with two distal canals, we have more of a trapezoidal or a rectangular outline, providing us access to adequately cleanse and address the presented canal anatomy. In two distal canals that are present 23% of the time, you can expect to a high degree of the time to be more trapezoidal toward rectangular in outline. But feel free to keep it as conservative as possible as long as it is adequate from the standpoint of providing all of the factors we discussed through direct visualization, straight line access, and complete instrumentation of the canal system. Some problems that may occur while accessing mandibular molars include gouging of the tooth. We may see this more commonly in diminished pulp chambers through calcification, through heavy restoration and reactive dentin deposition. The thinning of the enamel wall. So many times, the excessive removal of tooth structure will adequately weaken the tooth to the point where it's unsupported and cause fracture at some time down the road in the long-term treatment scenario. Lastly, we can, in worst-case scenarios, perforate into the furcation from using either too long of a surgical length burr or not knowing the dimensions before we start. So among these problems that we can access in mandibular molars, they can be overcome through astute preparation and understanding of the anatomical realities of these teeth. Other problems that can occur are in teeth that are heavily restored or that are uprighted through the use of crown and bridge dentistry. Many times, for aesthetic reasons, for periodontal reasons, a tooth will appear to be uprighted from the standpoint of the actual presentation of the crown in the mouth of the patient, when in all actuality, the root system is still at a very angulated or a sharp angle to the occlusal table. This has to be realized and it has to be understood before initial access is made. Lack of attention to detail, lack of visualization, radiographically, through palpation orally, through isolation of the complete system with the rubber dam, can lead to disorientation and in worst cases, as in the picture to the top to the right, You notice that the red dot, that's not the canal space. That is an iatrogenic perforation through lack of understanding and too mesial of a canal access preparation. So mesial tip molars, we have to locate the teeth and isolate the tooth adjacent and the tooth to the mesial and distal to that so that we can understand the natural inclination of the crowns of the teeth. This can also be accomplished through preoperative palpation and careful study of the preoperative radiographs to prevent such errors in canal access preparation. Some things and some hints that we can hold on to while accessing teeth are common from tooth to tooth. First, we'll notice that there's a change in the color of dentin. Simple changes in the color of dentin can alert us to clues of depth of penetration upon the actual canal preparation. Notice in this case you have a still very yellow opalescent view of the dentin, which was represented by what may appear to be the canal orifices. Actually, what you're noticing is you're working through the pulp horns. There have been holes that have been made through the ceiling of the pulp chamber, which will simulate or fool us into thinking that we've actually reached the floor of the chamber or the coronal aspect of the canal system. Here's another example of the appearance of dentin of the chamber floor. Notice the difference in appearance of a darker, more organic appearance in the presentation of this dentin. It's more organic in appearance, it's more supple when you look at it as compared to the dentin, which is yellower and lighter, of the axial wall, just to the bottom of the picture. This is what we're looking for clues in terms of our depth of penetration, not only through the depth of penetration, but in location of the actual canal orifices. Other problems that you may notice in accessing mandibular molars can be overcome by astute attention to detail. Once we identify the dentinal map that's present within these access preparations, we understand that the dentinal map will lead us directly into the orifices of the existing canals. This should be a very symmetrical presentation, one that we notice by following the dentinal map. If the canals that have been located fall outside of or in an asymmetrical pattern outside of the dentinal map, we can be assured that looking on the contralateral side of that canal, we will find the extra canal or the unrealized canal space. Once again, the dentinal map should terminate in the central portion of the canal orifice, and if we see one canal that is asymmetrical to the actual dentinal map, we should look on the contralateral side to identify extra canals so that we don't miss and that we can be thorough in the treatment of these endodontic cases. Failure to realize the presence of external or aberrant canals can lead, and is the most common way that we provide failure in the treatment of endodontic cases for our patients. So we must pay astute attention to detail in all that we do to identify all the canal anatomy. And again, this is overcome through proper and adequate canal preparation or posterior access preparation. In this schematic, I want to draw your attention to the top left-hand picture. That is preoperative before we begin our penetration phase and our access phase. As we move to the right, to the middle picture to the top right, we notice in our minds, we figure where the canal orifices routinely lie beneath the surface. Then to the far right top, we notice the initial penetration phase into the middle of the occlusal table of that tooth into the occlusal dentin, through the enamel into the dentin. Then in the lower left, we progress into the actual penetration into the chamber. We identify the canal spaces, and then we further enlarge as we move to the right. And finally, on the right lower left, we see a canal that has been not only all of the canal spaces identified, but it has been refined. We have direct visualization as well as radicular refinement and direct line access into the canal space. By visualizing this system, we all can get the feel that we can treat this tooth from the coronal aspect into the apical 1/3 successfully, and it has been accomplished through adequate posterior access preparation. A final couple of hints that we can take advantage of while accessing our posterior preparations is the use of magnification and illumination. Anytime we can see things on a larger scale with a direct column of light, it's going to enhance our ability to identify and to treat the anatomy that's present. We want to view this in a dry chamber, and we also want to look for the accumulation of dust into the natural anatomical orifices that are present. These subtle clues can help us to identify portions of the anatomy that may be overlooked and may be, in worst case scenarios, untreated, leading to ultimate failures. So again, astute attention to detail through use of magnification and illumination, viewing in a dry chamber, the accumulation of dust and identifying these orifices is one way that we have to overcome treatment failures. And this is illustrated in this picture, the small white areas that you notice through the use of magnification. Isolation with the dust. On the left will identify all of the canal orifices, and on the right will identify the elusive mesiobuccal 2 orifice that can sometimes haunt us down the road through treatment failure. We've covered a lot of ground, and we've discussed posterior endodontic access in a lot of detail. And if I could provide a summary and a few points that you could take home that will make an impact on your practice at your next treatment appointment, it would be the following. Remember, endodontic access has to be adequate so that all of the complex anatomy of the posterior tooth is addressed. Secondly, there needs to be straight line access of all of the instruments that are introduced into the canal system to improve the efficiency of those systems to accomplish the cleansing process. Thirdly, it should support a contamination-free seal of the canal system. And with these concepts, I hope that you can confidently proceed with endodontic therapy for your patients at your next treatment visit. Thank you for your attention.